Why only 75? Okay,
Because they,
you are live.
yes, sir. Yeah. Uh,
Yeah.
Good evening, everyone. So today's topic for discussion is stem cells and its role in infertility. So the regenerative medicine is now picking up in popularity and also in terms of finding usage in fertility practice. Because of one ART rules and regulations which are very stringent with the donor programs, and also because we know that this regenerative medicine, which has been under research for quite a few decades now, has found some kind of application in various other departments. So the same thing they extrapolated to fertility practice, where the degenerated cells who cannot self-repair can be repaired using these regenerative therapies. And mainly today we will be talking about stem cell therapy and PRP. I don't know, maybe sir will add a little bit. So over to you, sir, to stick to please only about stem cells and a little bit of PRP.
Actually, these days I heard from some of my friends that the quality of donors has become so bad that donors will require stem cell therapy to give eggs. Okay. But
No, true, true. It
but
is true. It is true because I think the requirement of donors has gone up so much, and there is a problem in the supply and demand. So I feel I don't know. I mean, the same people keep coming and donating unless we have a proper the ID tags in them through the ART banks.
okay.
Hmm.
So I'm going to be touching upon stem cell therapy in the next 10 minutes. And what is important for people to understand, and that is the take home point of this session. Shilpa madam asked me not to talk so much on PRP. It is right. We should not, because it is outdated. Okay. And the one thing which PRP does very nicely is it doesn't work in the ovary. Okay. It is like Dynogest on endometriosis, same thing. PRP, low AMH, ovary. Okay. Same correlation. It does not even give pain relief, in my opinion, PRP. Okay. So PRP is absolute nonsense as far as ovary is concerned. It has some benefit in the endometrium. Okay. And don't even touch it to the testis. Forget it. Okay. Fine. Now coming to stem cell therapy. Two things very, very important, which almost everybody misses out on. See, nobody wants to let go the patient off. Correct. So everybody will be like, I want to do something for the patient on my own in my capacity. So on my own and in my capacity is usually going to be PRP. So there will be some or the other indication which people will find for doing PRP and say, oh, PRP works magically in my hands. No, there is no such thing. What is important to understand about stem cell or any form of regenerative procedure which you do, okay, is at the moment in India, you are only allowed to extract the stem cells. Okay, you are not allowed to process the stem cells chemically in any manner. So you are not allowed to do anything which amounts to isolation of a particular stem cell line. That is not allowed in India. Okay, that is the first thing. Second, you are not allowed to do culture of any form of stem cells. Okay, you are not allowed to do that. Clear. All right. Third, please try and understand that stem cells for endometrium as well as for the ovary, there is no particular stem cell line which has been proven which works effectively over these two tissues. Okay, no particularly proven stem cell line. Okay, at this point in time, only Theca stem cells are being researched for the ovary in a big way, and endometrial stem cells, especially at the basal layer, are being researched in a big way. But it has not been isolated and proven that this is the most effective therapy. Now, once you isolate it, please understand you need a bare minimum concentration for it to be very, very effective. In order to provide a bare minimum concentration, you need to culture the stem cell. As long as you are not able to culture, your aliquot will not have such a high concentration. So this is one thing you have to keep in mind. Because of this, this entire therapy at the moment is considered to be an experimental therapy. Okay. It is not a labeled therapy. Currently, it goes in the category of an experimental therapy. If you look at our outcomes, so I was recently speaking to the founders of Seragin. They had come to my clinic over a cup of coffee. So we were just discussing that the stem cells in the ovary will have an effect of approximately 15%, not more than that. Stem cells in the endometrium will have an effect of around 55 to 60% and not more than that. Okay. Now please try and understand why did we say all these things. The biggest rate limiting factor in endometrial stem cells, okay, is hysteroscopy. It is not the procedure of stem cells. Stem cells, we have shown multiple videos. You need to go to the bone marrow. You have a particular time window in which the aspiration of the marrow has to happen. You have a particular window in which the aspirate needs to go inside the tubes for mixing. And then you have a particular window in which isolation has to occur. These three are very standardized windows. If you follow it nicely, you will get a beautiful progenitor cell aliquot. It is not called as a stem cell aliquot. You will get something called as a progenitor cell aliquot, where the minimum concentration of progenitor cells is going to be more than 10 in every high power field. Okay, on your slide preparation. So I think we are doing it very, very frequently in Bombay. We have started doing it in Bangalore, Chennai, everywhere. We give the slides of the prepared progenitor cells to the patient, and these are progenitor cells. Okay, so some or few of these progenitor cells would actually be pluripotent and totipotent cells, and they will go inside the endometrium and they will act by getting absorbed, okay, and cause regeneration to occur. Okay. The biggest problem at the moment is because of the amount of concentrate which is available is so low, okay, that on hysteroscopy you need to identify if that endometrium is viable or not. If it is a fibrotic, non-viable endometrium, your stem cell therapy won't work. If it is an endometrium which has more than 80% viability, then stem cell therapy is not needed. Okay, this 80% viability, more than 80% viability can easily be covered up with antibiotics and other medical management, and you don't require to inject stem cells inside. Many a times, because of the presence of synechiae, it is important that the synechiolisis is done correctly to expose the basal endometrium nicely. Many a times it is important that in previously operated cases of thin endometrium, when you have this micro polyps, okay, these micro polyps are identified and you give antibiotic therapy, automatically the lining for the endometrium will become better. Okay. Also remember, when you put inside stem cells, there is not going to be a massive increase in the endometrial thickness. It is the appearance of the endometrium which goes up. So if let's say you have a 5 millimeter endometrium, 5 millimeter endometrium does not become 25 millimeter endometrium. After doing autologous stem cell transplant, 5 can become maybe 5.5 or 6. But the way in which it is looking from inside and outside, the receptivity and the nature of the endometrium becomes better. Now, this is even more tough when you do it in the ovary. The reason why it is even more tough in the ovary is because ovary is formed completely of cortex. Majority of the times when people inject, they inject absolutely wrong. They inject in the hilum, somebody will inject in the IP ligament, somebody will inject. Somebody told me that somebody was doing a drilling and they went straight inside the external iliac vein. So all such types of things can happen when you are doing autologous stem cell therapy in the ovary. What is important to understand is that once you prepare the aliquot, you need to go subcortical. And once you go subcortical, that ovary AMH will not increase. That ovary's antral follicle count will probably stay the same, but the quality of the oocyte will or may increase. Okay, which is why autologous stem cell therapy in the ovary is usually recommended when the antral follicle count is approximately 1. Okay, or when the FSH value is approximately 15 to 16. You may do it in values more than that, but that may or may not be very effective. So what we have realized from our data is that the volume of the ovary is a very, very important aspect if the stem cell therapy will work or not. And it is not really the age of the patient, it is the volume of the ovary. If the ovary is a very low volume ovary, then no matter what you do, stem cell therapy might not go ahead. Okay. I personally I'm of this opinion, very strong opinion, because we do quite a bit of stem cell therapy, is that the patient counseling for stem cell therapy has to be very, very accurate. Okay. You really need to tell these patients what will work and what will not work. You really need to tell them what is the importance of doing a good hysteroscopy and a good laparoscopy. Majority of the people do stem cell therapy thinking, "Arey, hysteroscopy anybody can do." Anybody can do, but anybody can't do it so nicely. That is the big problem, and that is the rate limiting step. So if you really want to take home something home today, is that forget the stem cell therapy for the time being. You can't really say that you have one patient in a year who has thin endometrium and you want to do stem cell therapy and get the same outcomes like everybody else is getting. All that chant, all such sort of things are not going to happen. तो वो सब ख्वाब कुलाओ को भूल जाओ. Okay. What is important is do a good hysteroscopy. 50% of the times, and I'm sure Dr. Shilpa would agree to this, we've had excellent outcomes with stem cell therapy because we are doing excellent hysteroscopy. We are taking out all the calcifications. We are identifying the micropolyps. The opening of the cavity is absolutely beautiful. When we are dealing with Asherman, we are going right in that subendometrial plane. When you go in the subendometrial plane, you are going in the subendometrial plane. You are not exposing the myometrium. When there is no exposure or limited exposure of the myometrium, the chances of repeat adhesions is very less. And through the cervical lining, there is going to be lateral epithelialization, which will go inside the endometrium. And when you deposit stem cells inside that, or when you deposit a progenitor cell alicot inside that, it will stimulate that growth and healing reaction. At the moment, that is what it does. Okay, at the moment, what we know is stimulates growth and healing reaction, which may benefit. Okay, please remember again, before I conclude, I'm repeating no role over the testis, 100% no role. So don't recommend stem cell therapy for azoospermia. You are going to be counted as a fool. Okay, don't recommend it at the moment. Even if you have invented stem cell therapy, you think so, don't recommend it. Okay, second, in the ovary, 15% benefit maximum. Ovarian volume is a very, very important criteria to assess prior to giving any patient an advice of doing stem cell therapy. Okay. In the endometrium, the game changer is a good hysteroscopy. After that, if you put in stem cells, it may benefit. Okay. Now I said all this Ram Kahani about stem cells. Why is it that I'm saying that PRP is not as effective as stem cells? Okay. Please remember, PRP has no progenitor cells. Okay. PRP has only platelets, and the amount of cytokines with the platelet is able to produce and throw out is way more less as compared to an alicot of progenitor cells. The reason is this alicot of progenitor cells induces a lot more inflammatory reaction. Okay, and this lot more inflammatory reaction automatically supplies enough long-term chemokine, cytokine, prokine, cytokine, whatever you need in order to develop that particular tissue. Okay, if you say you will just put PRP and you will be fine with it, remember PRP will work beautifully in combination with therapies like steroid injections or something over the hair. That is because the distance between the two hair follicles is really, really less. It's hardly any distance between those two hair follicles inside. So even if you inject 0.4 ml, you have injected in 50 hair. It is like that. That is not true for ovary. That is not true for endometrium. In fact, the joke is people try to do transvaginal injection of PRP in the ovary. 80% of the alicot stays in the pickup needle. Okay. You don't really want to go and regenerate the pickup needle. Correct? No? You want to go and regenerate that ovary, isn't it? So when you plan to regenerate the ovary, you really need an air gap to be pushed inside. And doing it transvaginally is absolutely a waste because you cannot enter into the subcortical plane at all. Okay. You will go deep, you will go close to the hilum, 100%. Because these ovaries are small, they are mobile, and they don't have follicles. Okay. So don't really think that you did an ovarian PRP and it worked wonders. It will work wonder, but on the peritoneum because majority of the PRP will spill in the peritoneum and it will be a beautiful peritoneal reaction and not an ovarian reaction. Okay, so keep that in. Same thing about hysteroscopic PRP injection. When people say, I do beautiful subendometrial PRP injection through the hysteroscope and all these things, it's wrong. You're putting the water pressure on. When you put the water pressure on, whatever you inject, water circulation inside the cavity will throw it out. So if you've ever seen us doing stem cell injection or PRP injection when we were doing inside the subendometrium, that means inside the basal endometrium, you put the needle, you stop the water pressure. Okay, and then you inject. Or if you've already caused an injury, like if you've already done Asherman or something like that, you put it simply through an embryo transfer catheter or an IUI catheter, whichever you have available. But even in that, you push it very slowly over 10 to 15 minutes so that the uterine contractility will absorb all of that. It will pass it inside the myometrial aspect and then stimulate that reaction. Okay. So just keep that in mind. With that, I conclude. I shall be happy to answer 2 or 3 questions, but I have finished my 20 minutes.
Yeah. So this volume of the ovary, you have been telling more and not the age of the patient, isn't it? But don't you think age of the patient is also equally important when it actually comes
It
to
is, it
borderline
is, but then,
femicide?
madam, these days there are so many young patients and old patients, both with very low AMH.
Hmm.
So honestly, one can't really tell that a 44-year-old with AMH of zero point 0.2 and 29-year-old with AMH of zero point 0.1, which one to choose to put ovarian stem cell therapy? The answer is you need to choose both, or the answer is just do an ovarian volume, and you will come to know that what is the if the younger patient has a lower volume, that's a bad thing.
But usually, have you seen that these younger patients who come with low AMH, their volume is not very low. I
Yeah,
mean, it's
that's what
with
I'm saying. Younger patient with a low volume is a bad thing.
that case, yeah.
Usually their volume is not low, but
Mm.
uh, but if their volume is low, then 100% nothing will work.
Okay, tell me what is the role of E2 in cases of like ovarian when you decide on the ovarian stem
E2
cells?
less than 9 has then there is no role. Basically, that ovary has gone into failure.
Mm-hmm. And how do you check the success? Like, how do you say that your stem
So
cells?
we repeat the FSH after a month
Mm.
and E2. The FSH should have dropped to less than 10. The E2 should have gone to more than 40. And it will go more than 40 only if there is development of an antral follicle. Otherwise, the E2 cannot cross 40.
Mhm. And so I think we have done more of endometrial stem cells,
Endometrium.
uh, the ovarian stem cells, and as you said, the rate limiting step, which is the hysteroscopy, that is the I feel it is the most important step, and your adhesiolysis, I think it is quite complete. Like because we get a little scared when we go near the fundus where we'll perforate the whole thing,
Yeah,
and we have to do it under laparoscopic guidance. But I've seen that you do it like extremely well and more complete than what actually like we do. So you said 20 to 20% of the cavity should be uh,
viable.
yeah, viable before we even take it. How do you,
Yeah.
so even before we post them, so do you have any criteria where we can follow, like a scan criteria or something where we tell them that, okay, it is feasible for you, or is it an
No,
on-table decision?
it's an on-table decision, especially in Asherman. If it is just a chronically thin endometrium, then you will come to know if it is a thin endometrium, most of it will be viable. Stem cells will usually go and work. There will be a patch of, hypoxia inside that
Mm.
chronic thin endometrium without Asherman. You will come to know about it. It's very easy to find. Look at it and tell.
Mm-hmm. So between the two, like I know Asherman's the response will be a little
The
lesser
best. No,
compared.
Asherman response is the best because Asherman is completely corrected, pathology is gone, and then you put the stem cell. In
Mm.
thin endometrium, idiopathic thin endometrium, you don't know the pathology. Okay. Which is why in idiopathic thin endometrium, the response may or may not be very conducive.
Really?
Yeah, may or may not be. But in Asherman, if the Asherman is corrected nicely, So the response rates are usually good. People will start to bleed. They will experience menses.
Really, I mean, even Asherman's, see, you think Asherman's, like, if you do a proper adhesiolysis, the cavity is more
It's
conducive.
transferable. Yeah, it is transferable. We've had so many embryo transfers. So many of them have become pregnant.
Even when, see, why does Asherman happen? It is because the basal layer is destroyed, and
Correct.
myometrium to myometrium, there will be like the adhesion,
Adhesion.
and you cut it open. So how can that, like, I mean, even if you cut the bands, isn't it the basal layer is completely destroyed here?
Some part will remain, madam. What is destroyed is what we think is destroyed. Right?
Mm,
It is not. See, if the myometrium has gone and got adherent to the myometrium, you should not even see an endometrial stripe. The
mm,
reason why you see an endometrial stripe is because there is something remaining somewhere,
yeah,
and
yeah,
you are banking on that.
yeah.
Understanding?
Mm. So yeah, I think I agree with you because when we do the scan, who come for adhesiolysis with you. So when we
You
do
will see
the
a stripe.
type, yeah, yeah. So though it is patchy,
It
even
is
we have
patchy.
seen the triple line, though it is patchy, like somewhere near the fundus or
It's a it's a focal triple line
yeah, focal
in
triple.
Asherman. It's a focal triple line, and sometimes in Asherman you will have this blebs,
Mm,
hypoechoic water collection
mm,
basically, or
mm,
endometrial fluid collection sort of, which is loculated. That is
mm,
again due to the myometrium getting adherent to the myometrium. So when you go inside and cut it open, that fluid will just gush out.
mm, mm, mm. Okay, so you think the time factor between the stem cell collection, processing, and putting it back is one of, again, a rate limiting step for the
Yeah,
success?
yeah.
Why do you think so? I mean, is it because they are
Majority
so,
of the factors get destroyed in that process.
the fragility of the cells, you mean?
Yeah,
Okay, I mean, okay, but see, we see so many of these companies. I mean, let's not name them. So they have a tie-up with the fertility center. They come with their
correct.
team. They do the bone marrow aspiration
Creation.
at test, and they take it to their lab, which is like quite a distance, which may take about at least like half an hour to reach. They process it, they bring it back. So all this will take at least 2 hours. Okay, because
Yeah,
everybody is equipped in doing the processing and isolating the alicot like you are. So you think, I mean, the potency of the pluripotent stem cell will drastically reduce in these cases?
it will reduce if there is a time to preparing the alicot. It will not reduce once the alicot is prepared.
Yeah, so preparation of the alicot also is going to take time, right? I mean, because they have to
Yeah,
transfer it from the center
yeah,
to their place.
yeah, yeah. So what I've heard is quite a lot of them they centrifuge at the location, and
Hmm.
once they centrifuge at the location, then they carry it, to the desired destination where the plasma is taken off already. So once the plasma is taken off, usually the risk of the factors getting disintegrated.
Hmm.
What is the problem? I'll tell you. If the RBCs get disintegrated, no, it affects the whole system from inside, which is why we want to pick off the layer just above that first RBC, you know, and prepare it. This stem cell alicot, which is obtained, is not white in color. It's actually reddish maroon in color, sort of, because some amount of RBCs will come any which ways. Understanding? I mean, unless you are using ultrafiltration, which nobody uses. So what typically happens in this situation is majority people would try to manage that hemolysis. They don't want that hemolysis to set in to affect the other factors. Once hemolyzed, it will cause clumps. Once it is clumped, it will not be able to give a good adequate. Okay. So they will do something or the other as far as preparation is concerned prior to transport, madam. But if you do
So,
everything in-house, it
hmm.
definitely works better. You've seen
So
that.
what is the role of GCSF before you do the stem cell therapy? Do you give the GCSF?
You should never give it. If you give the GCSF, the marrow will be empty. All the progenitor cells will go out of the marrow in the peripheral circulation.
Mm-hmm.
So you should not give that, madam.
Okay. And in a month, like how many you do, and what is your consent like? I mean, do you take a video consent?
Experimental procedure consent. It's a written experimental pre-printed consent, and patient has to sign on it before they do the procedure.
Mm-hmm. So, if at all, if you think that it has responded, when do you ask them to do the embryo transfer, or even like,
After 2 months.
uh,
After 2 months.
so it usually
And
takes 45.
stimulation after 45 to 60 days.
Mm-hmm. So post the stem cells, especially after hysteroscopy, adhesiolysis, and stem cells, do you give them estrogen, progesterone
Yeah,
medication? Do you,
yeah. Better to give.
yeah, and what about interseed? Do you add interseed into the cavity
I
after?
I tried a lot of interseed in
Mhm.
lots of cavities, but I think the long-term results, even with the interseed, are the same, madam. You just need that separation to occur maybe for 12 to 13 hours. And once that much separation has occurred, some amount of epithelialization occurs in that 24-hour window. Okay. And probably we don't need interseed.
Mhm. Okay, yeah. I think the rest of the questions will take on the groups. Do you want to add anything?
No, I just want to tell people that do not do not run away from good therapies by doing something which is substandard. Don't do that.
Yeah,
There is
correct.
no such
Okay.
thing.
Yeah, sorry. I wanted to ask this. See, there are so many ready-made PRP kits available. See, I've never done a PRP in my entire career. Okay, not
Yeah.
when it is very popular, and not now when it is found to be not so good. I have never done it because I didn't believe in it actually. So now there are so many ready-made kits. Like, every other company comes and gives out a flyer saying the brochure saying that, PRP, this is the kit that you need to use for 2000, 1500 and all such things. So, what is your thought? Like, I mean, really, to be honest, I mean, are we just like, making the patient spend their hard-earned money on such things which are not found to
Yeah.
be useful?
Yeah. I think
Or
so.
are we desperately trying to do something because we empathize and sympathize with the patient because we are not left with
We we
any
we
options?
empathize, we empathize and sympathize, and on top of it, we don't want to refer also. So that's a common problem. I mean, that's a big problem in India.
Yeah, but I mean, how many stem cell centers do you really like, or do you think that they are doing a decent work in regenerative medicine?
I don't know. I don't know. I think I only stay in communication with. I try to stay in communication with NIRRH. They are big people. It's
What's
National Institute of Reproductive Health, and there are wonderful scientists working on this. Some of them are even our Facebook friends, my Facebook friends, and they are doing a great job. So one has to align with what the best scientific minds in the country are speaking about it, right? You can't really wear.
In
Uh,
which of the areas you think the stem cells have really worked wonders? Like, I mean, endometrium 55%, ovary is like hardly 15%. But
yeah,
where in which other organs you think stem cells have worked very well? What do you think?
I don't know, madam. At the moment, I don't know
Mm.
because there is no there is no license to culture and isolate. Please
Yeah.
understand. It's like talking. It's like how people fool these young couples, oh, the ones who are pregnant. Oh, you come and bang the cord, or how people wear fancy jackets and conduct conferences and say, oh, adipose stem cells are great. Okay, try take out fat, lyse the fat, and remove 10 stem cells from that and show me. Okay, it's very good, yeah, when you talk all this nonsense in air conditioned rooms. But when it actually comes to real life of the patient, all this is not the current applications, in my humble opinion. Okay, at the moment, till we are not able to culture it, the option is bone marrow, because bone marrow has the highest concentration. Okay, it is the place where it's the bank basically. Okay, you can't really go to an ATM and say, "Oh, I minted more money from the ATM than the headquarters." That's not possible. Correct. So one has to go to the bone marrow, has to take out the bone marrow till a time comes that you can culture and isolate these stem cells. Till you can't, don't really, I mean, take it as an experimental consent and don't really give high hopes. If you really have the guts, prepare slides, give it to the patient. Okay. You can't really say that you did stem cells and you put water inside it. All that is not correct, in my opinion.
So you think this is something which is replicable for everybody if they put their mind and heart into
No,
it and start doing
no,
it?
no.
Like how
It requires
the kits are available now. Do you think eventually the stem cell kits also will be available wherein you can start doing it by yourself?
No, I don't think so. I don't
Why?
think so. It requires a very good process of centrifugation and then picking up that alicot. That nobody can do. That you need that experience to pick up that alicot, and that alicot preparation is usually manual or at least semi-automatic. It's tough to pick it up, and one has to pick it up with experience, is what I think.
Okay, yeah. I think, yeah, it was good. Thank you so much.